Let's now turn our attention to something that may confuse us, and that is the hemorrhage into a cyst. But before we consider the ways that it can confuse us, let's first consider the possibility that we were all smart enough to know that we were actually looking at hemorrhage into a unilocular cyst. If that were the case, we would know that this was most commonly a follicular or corpus luteum cyst. Clearly more commonly corpus luteum cyst, but occasionally a follicular cyst. It has been noted in benign unilocular cystic neoplasms, but has not been noted as hemorrhage into the cyst of a malignant unilocular cystic neoplasm. You want to discriminate what we're talking about here, hemorrhage into a cyst, from the hemorrhagic component of a solid portion of a mass in the ovary. That is highly characteristic of malignancy, but not something that we see sonographically. That's a feature that would be seen on MRI. So separate those two things in your mind. If we see hemorrhage into a unilocular cyst, not only would we be highly confident that this was benign, but we would almost be certain that it would resolve. When does it get confusing? Well, those diffuse low-level echoes in a lesion may make us think we're looking at a solid lesion. So here is a mass where it's not that easy to see acoustic enhancement. It's not easy to be confident we're seeing a wall. Maybe we are, maybe we're not. These are not simply all low-level ground glass echoes. There's a few slightly higher amplitude echoes in there. We have some concerns. Adherent clot may make us think we're looking at a mural nodule or other mural feature. So here we see this mural feature. Is that adherent clot, or is that growth of a neoplasm? Well, actually here we can tell that it is not neoplastic because no neoplasm grows with a concave margin. And also, if this were neoplastic tissue growing in from this wall, it would have the same echogenicity as the wall. This is what we see with true mural nodules. True mural nodules have convex margins, convex margins, and they have the same echogenicity as the wall that they grow in from. And finally, the most problematic thing are fibrin strands within the blood clot. They may make us again think of using the word septation. So if we look at this lesion and say, ooh, septations, I'm dictating the word septations, we're in trouble because the gynecologist will interpret that you believe it's a neoplasm, and by the time they go to the OR to take this thing out, it will be gone. That's when you get that fateful call from the operator, from the OR, saying, doctor, could you please come up here and show us this mass we've opened the patient up to remove? How do we tell the difference between clot and septations? Well, I'm here to tell you that there's no foolproof method of doing it. So caution is the word of the day. However, here we see a lesion that has 30 lines in this one cut that we might think of as a septation. This is typical of clot and fibrin. Look, I've seen neoplasms with 30 septations in them, but they don't have 30 septations per cut. There's simply too many of these things to be septations in a neoplasm. So again, there's far too many of these little lines to be septations in a neoplasm. Another thing you can say about septations in the neoplasm is that when you look at them on a cine clip, you will notice that they more or less make sense. This one flows into that one flows into that one. Whereas if you try to do that with this lesion, your eyes spin around in your head. There's just too many of these things. They're simply too weird to be septations. So here we see a neoplasm with septations, a typical hemorrhagic cyst, and here we see a lesion in the opposite ovary that has diffuse low-level echoes, visible wall, acoustic enhancement, and a bright reflector in the wall, a typical endometrioma. So neoplasm with septations. Hemorrhagic cysts with innumerable fibrin strands, and an endometrioma in the ovary.